Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. It's Angela Huttner here. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comps. We are coming back to our nightmare series today, though we really didn't want to. Anti-vax sentiment in the US and elsewhere is surging. The reality is that people soon to be in power in a powerful nation are questioning the value of many vaccines. A lawyer to the man who will likely be the United States Secretary of Health has asked that approval of the polio vaccine be revoked in that country. The destruction wrought by the polio virus was well documented and well lived by our predecessors, but most people alive today have not seen polio or rubella, and most doctors in practice today have never handled a case. So for this episode of Communicable, we've brought together two expert infectious disease clinicians who have. With them, we'll go through the basics of these two viral diseases that are rarely seen in most places today. Our first guest is Professor Bernard Hirschel, Professor Emeritus of Infectious Diseases at the University of Geneva, here in Switzerland, and former head of the Geneva University Hospital's HIV unit. And full disclosure, Bernard was once my boss, and was and is an important mentor to me. He also happens to be the physician who treated the last known case of polio in Switzerland. And although he is officially an adult ID doc, as a fourth-year medical student working in Cameroon, he worked in a pediatric ward during an epidemic of polio and measles.
Hello, pleased to be here.
Thanks, Bernard, for being here. Our second guest is Dr. Kerrigan McCarthy, a clinical microbiologist and pathologist in Johannesburg, South Africa, where a large rubella outbreak is ongoing. Kerrigan is based in the Center for Vaccines and Immunology at South Africa's National Institute for Communicable Diseases. Her responsibilities include surveillance, epidemiology, and laboratory diagnostics, and outbreak investigations for measles, rubella, polio, and hepatitis viruses. And surveillance includes leading the NICD's wastewater surveillance team. Have a look at our recent episode on wastewater surveillance. Kerrigan, really happy you could join.
It's wonderful to be with you, Angela and Bernard.
As our listeners know, we start these episodes with a sort of get-to-know-you question. I'm going to give a really obvious one because it's January. My question is, what is one of your New Year's resolutions for 2025? So I'll start with mine. I usually have all these resolutions and I'm super ambitious and then I don't really achieve any of them. So this time I thought, okay, I'll just do one. And mine is to sort of be instead of do all the time. We'll see how it goes. Bernard, how about you?
Well, we're talking about polio. So there is this eradication of polio program that has existed since 1988 for 2025. I think a realistic aim would be to have 0 new cases for a year. It's very close. There are actually a dozen or 20 new cases of wild-type polio in the world per year in the last few years.
That's great. But this was a get-to-know-you question, Bernard. This is supposed to be about you.
I don't have any serious New Year resolutions. But conditions for skiing are fantastic this year, so I hope to get some good skiing in the next few weeks, which would be a resolution. I'm retired, so I can allow myself some levity, I think.
I think that's smart. So Kerrigan, how about you?
Thank you, Angela. So I've ceased to have any New Year's resolutions because I find they often short-lived, and what I prefer to do is hope and respond to what comes my way so that I live a meaningful life and to take advantage of opportunities and directions that allow me to transform situations into something that is meaningful. A good example of that was a few years ago, I landed up in a new division, my current Center for Vaccines and Immunology. And from the polio eradication program, we branched into wastewater surveillance and has become something of global interest and hopefully global significance in time.
I love it. And I think you're in very good company. So here we are, beginning of 2025, globalized world, hopping from continent to continent, quite easy now, with many children who for the next few years will maybe not receive vaccinations. So let's start with polio. First off, Bernard, can you paint a picture for us of what the world was like when there wasn't polio vaccine.
Well, I was born in 1946. Polio vaccination started in 1956. So I remember well that, for instance, swimming pools were closed in summer because of the scare of polio. Polio became a really important issue because of an increase in paralytic cases during the early 20th century. There was little talk about polio in the 19th century. And it is thought that with better hygiene, infection was later. And therefore, because polio is more virulent in older children and young adults, the cases of paralytic polio increased, reaching almost 100,000 per year in the early 50s in the United States. So these epidemics caused panic, and the vaccine was eagerly awaited. We had a nanny whom we loved very much, and her child had polio. And then I saw polio again in Africa when I was a fourth-year medical student. There was an epidemic. Walking through the villages, you saw people who probably had polio because they had this characteristic atrophy of a leg or so and were limping along. And of course, then there were these very famous cases like FDR, who had polio. I think his case was quite typical.
Just for our full global audience of young people, FDR stands for Franklin Roosevelt, very famous polio victim. Yeah.
For present day people with sequelae of polio, you can look to Itzhak Perlman, who is a world famous violinist, and you can see when he hobbles onto the stage in YouTube how serious his handicap really is. So polio is a very serious infection when it touches the central nervous system, and there was no controversy about vaccination when it appeared. It is almost 100% effective. It has almost eliminated polio, but as long as polio cases exist, the only way to protect people is by vaccination. There is no drug, nothing you can do once it happens.
Can you give us a brief refresher on the virus itself?
Poliovirus is an enterovirus. It's a picornavirus. Pico means small, and RNA means, well, ribonucleic acid. The smallest pathogen, I think, that exists. It has only 7,500 nucleotides. It has been completely synthesized in vitro, one of the first viruses where one was able to do so. It is a plus virus, meaning that when it gets into a cell, the nucleic acid that is liberated in the cell functions as a messenger RNA and codes for 10 proteins. Among them, the proteins which determine the types of polio. There are 3 serotypes. And the virus is a enterovirus, meaning it's in the gut. The symptoms are usually non-specific, some sore throat, diarrhea, little fever. In most people, it's asymptomatic. And then in a few percent, it goes on to cause an infection of the central nervous system, where it attacks the anterior horn cells, which control motricity. And typically, the disease starts with a maximum effect. The paralysis becomes maximal within a few days and then recedes to a various degree. In a small minority of patients, the virus touches the brain stem, and this can lead to a respiratory paralysis. You probably have seen these iconic pictures of iron lungs, which were the only way to sustain ventilation in the 1950s, since, of course, replaced by intubation and all that. So in that way, the disease can be fatal because of respiratory paralysis, aspiration, pneumonia, etc. So that's in a nutshell what polio is.
And so for the sort of tropism, let's say, of this virus, what does it need to get into a human cell?
Well, humans, for all practical purposes, are the only susceptible species. They have this receptor, CD155, and therefore there are no animal models. It is a mystery why some people get neurological complications and the majority doesn't. There are some speculations, maybe viremia in the beginning is more intense and symptoms are more intense, but I really don't think that one knows why some get infected or not.
Yeah. And so most people, like you said, are asymptomatic. How many in percentages? What would you say?
Well, of course, because symptoms are so non-specific, who knows? But at least 3/4 are completely asymptomatic, and another 20% may have minor symptoms of a viral infection. And then the rest will get some neurological involvement.
And this may be why you could sustain an anti-vaccine argument, because the majority of people really are fine with a polio infection and will be for the rest of their lives, correct?
Well, I mean, if you look at what the arguments of the anti-vaxxers are, there are three different strands of argumentation. One is the mercury thing. Mercury used to be a preservative in vaccines. It's no longer used. Some people think that is related to autism and other problems. The link has been debunked for a long time. And anyway, there is no more mercury in vaccines. The link to autism has been claimed for many different vaccines. It is non-existent. And then there is a specific problem to polio. There are two vaccines. One is a attenuated but viable strain. The living vaccine has many advantages. It is very cheap, so it doesn't need a sophisticated cold chain, and it is infective in itself. So if you have a vaccination campaign and let's say you reach 60% of susceptible people that should be vaccinated, they will excrete the virus in their feces, and where the sanitary situation is precarious, they will infect other people with the vaccine strain. So the vaccine spreads. That's a big advantage. But it has a disadvantage. In very rare cases, the virus may become virulent. Virulent for the patient who gets vaccinated. That's 1 in a million or so. He will get neuropolio himself or herself. That's why the oral vaccine in Europe and the United States has been abandoned for about 20 years. It is still used in developing countries and is still endorsed by the WHO because of its great effectiveness, cheap price, and other advantages. So that could be an argument against the oral vaccine, but the oral vaccine is no longer used in Europe and the United States.
Yeah, fair enough. If we were to do like a mini review, we covered the virus itself. What about clinical presentation? We already established that most people are going to be completely asymptomatic, but those who are symptomatic, how do they present? What can a doctor who's never seen this virus expect? What should we be looking for to make the diagnosis clinically?
Many patients have pain in their legs, cramps and pains in their muscles. The patient that I saw in 1980 was typical. This was a man who was infected by a vaccine-related strain. He was himself, of course, not vaccinated, otherwise he would have been immune. And he had pains and cramps in his legs in the morning, and then he had a big lunch and went to sleep thereafter. And when he tried to get up, his leg just gave out under him and he fell to the floor with a pain in his leg. So that would be a very typical story. Then what is typical also is that the paralysis rapidly progresses. Within a day or two, it is maximal, and then it recedes slowly as the immune response kicks in.
So this man was already in the neurologic phase when he was diagnosed. When was he actually infected? What does the initial infection look like in those few who are symptomatic? It's an enterovirus.
Well, it is completely non-specific. There are people, they will complain of fatigue or a little fever, diarrhea, sore throat. But in most cases, you cannot diagnose a polio infection and distinguish from any old enterovirus or other virus in the population. I guess within an epidemic, you would maybe have a higher index of suspicion and could diagnose the pre-neurological infection by cultivating the virus from feces. But that's not a practical proposition for isolated rare cases. So I guess if you saw a case now, which is very unlikely, the first thing you would think is it's something else. But if there was a case, you would probably detect it only during the neurological phase.
Yeah, because that's when it gets more specific. And what was the lag time between that initial infection and the neurologic phase?
Well, this is a few days to a week or two. There is the post-polio syndrome, which is something different. This is in survivors of polio. They have deficits. They adjust to these deficits for 10, 20, 30, 50 years. And then suddenly in the affected leg, the remaining strength decreases. And it decreases at various speeds, something like 1% per year on the average in strength, with periods of remission. Because this is motor neuron disease, this is of course very alarming because you start thinking of ALS, amyotrophic lateral sclerosis, which is a devastating, always fatal disease. It's not the same. It is a decrease in strength. And of course, with the handicap, which is already there, and people are old, their general muscle strength decreases, it can be a serious problem. But that is very different from acute polio.
Can post-polio syndrome happen at any part of the body, maybe a part that wasn't clinically affected in the neurologic phase earlier?
Well, it mostly affects the parts of the body that were initially involved when the neurological polio declared itself.
So then what's happening? Does that mean the virus is still there? It's been latent? What's going on?
There are theories that, of course, during the recuperation, the same motor neurons which innervate a muscle group sort of take over the work of other motor neurons. And instead of innervating 10 muscle fibers, they innervate a few hundreds. And in the long run, this sort of exhausts the neurons. Not a very scientific explanation, but that's what you can read.
Is there any evidence that there's virus that's persisting all these years?
I don't think so.
Interesting.
The antibodies are neutralizing and they go on and the virus is eliminated. Now, I would say that the very persistent protection which exists in polio and measles, for instance, makes you think that maybe there is some antigen somewhere in the body which keeps the immune response active. But I don't think that has been proved for polio.
Have there been cases of a new infection with polio in someone who already had one infection with polio, or is it almost never?
Well, yes, there are, of course, these three serotypes. And when you're infected with a natural poliovirus, you have antibodies against type 1 if you are infected with type 1. And there have been proven cases of infection with the other types after a natural infection.
So antibodies are quite specific.
They are half specific, at least, yes.
Do we know, by the way, what the correlate of protection is? Is it antibodies?
Yeah, I think this is a case of neutralizing antibodies that are effective, at least after vaccination. That's what it is.
Coming back to the basics, somebody who's potentially going to be faced with polio infections, how do you diagnose poliovirus today?
Well, you isolate the virus from feces, and then you want to sequence it, because what you need to do is to distinguish natural polio from vaccine-related polio. This used to be by oligotyping, which is a sort of a complicated two-dimensional electrophoresis. That's no longer done now because sequencing and reverse transcription is so easy. And that's also how polioviruses in wastewater are discovered.
Kerrigan, any words there from your side in terms of wastewater surveillance?
Well, I can add something around the diagnostics. Our country and institution is the polio reference laboratory for the region. We have, of course, an active surveillance program for acute flaccid paralysis. So polio, of course, presents with a sudden onset, as explained. But the differential diagnosis is broader than polio. There are a number of other conditions that present in a similar way. The key thing is to conduct the laboratory diagnostics in anyone meeting the case definition. So in our surveillance team, we have a whole lot of surveillance officers who are usually nurses who work closely with clinicians to identify cases of acute flaccid paralysis. And following these cases, stool is submitted for culture. This is one of the challenges of the polio elimination program, is that culture is time consuming and it requires a very sophisticated laboratory environment. One has to have cell culture facilities and then to inoculate stool samples into the cell culture and then to be able to have the technological expertise to detect a cytopathic effect. That is a sort of a clumping of the cells when the poliovirus is present. And then, of course, there's a double culture process where we first inoculate non-specific cells, and then if it looks like there's a poliovirus present, then we inoculate cells that are modified to have that CD155 receptor or CD150 receptor that then these cells will only be infected if polio is present. And thereafter, we go and do sequencing. And that whole process can take 2 weeks before you can get a negative result. If there's a positive result with a positive cytopathic effect, usually occurs within 3 to 4 days, and the process perhaps can be completed in 7 to 10 days, where you have a positive virus cell culture and then you need to sequence it. And this means that the turnaround time for identifying cases of polio is very long. And we also have to factor in that these specimens are sent to us from a number of African countries. And so then it becomes very difficult to respond meaningfully to outbreaks. One of the new areas for research, which has sadly taken a rather longer time than in other communicable diseases, is the development of direct PCR testing, where we test stool for polio. And this takes a while in terms of rolling it out within the global polio eradication program. Unfortunately, it is less sensitive than culture, which is the gold standard. So, even if we do add in direct PCR testing, we're going to miss a few cases. Your question about wastewater is interesting. So environmental surveillance has a lovely history with regard to polio. It was noticed in the polio outbreaks in Scandinavia in the 70s and 80s that wastewater in towns that had polio epidemics were testing positive for poliovirus. Of course, the virus is a very hardy virus. It doesn't have a cell envelope, and so it's able to survive in the environment and even remain infectious for a long time. The association between environmental contamination during an outbreak was initially sort of interest value, and then it was realized that because of the very low symptomatic ratio in polio, that if you have large numbers of people, the burden of disease is more likely to be reflected in the environment than it is in symptomatic cases. And so people started testing wastewater, and eventually the evidence was overwhelming, and the WHO incorporated environmental surveillance into the global polio eradication program. What we've seen in our reference laboratory here is where we do testing both of stools in cases with suspected polio, in other words, acute flaccid paralysis, and we do environmental culture that we often find neighboring countries that have polio neurovirulent viruses in their wastewater, but they haven't detected clinical cases of acute flaccid paralysis. These are vaccine-related viruses. So at the moment, and I don't want to jump the gun, your question is where's polio, wild polio endemic in the world? Wild polio is endemic in Afghanistan and Pakistan at the moment only. In 2021, there was a case of wild polio identified in Malawi and Mozambique, in the area cross-border migrants between the two countries. And genetic sequencing identified that this virus had an origin about 18 months prior in Pakistan. The continent did not lose its polio-free status because it was deemed to be an imported case, and there was a robust outbreak response with vaccination, and the wild poliovirus type 1 hasn't been detected subsequently. But obviously this has been a very busy time for our laboratory. I can go back to the wastewater surveillance. So in our country, South Africa, we do wastewater samples for polio. We process them for a number of countries, and 2 countries on our border, Botswana and Zimbabwe, have both had vaccine-derived poliovirus. This is VDPV2, vaccine-derived poliovirus type 2, in their wastewater over the past 24 months. They have not had clinical cases of polio due to these same viruses at this stage. Now, the reason for this is likely twofold. The first is the low symptomatic to asymptomatic ratio. So about 98 to 99% of persons with polio infection will be asymptomatic, and only 1% will develop symptoms of paralysis. If one's clinical surveillance program is weak, these few cases may go undetected. So it's highly likely that an individual with paralysis will be taken by their caregiver to hospital, but the clinician might not submit samples for surveillance testing and diagnostic testing, and we will likely miss them. The second reason is that in individuals, and this is less likely in the African continent, in individuals who've been vaccinated with the inactivated polio vaccine that Bernard was talking about, these individuals may still be infected with the live polio virus because the inactivated polio virus only induces an immune response in the blood. It does not induce a very strong immune response in the gut. And so what it means is that the initial ingestion of a wild poliovirus or vaccine poliovirus in someone who's been vaccinated with inactivated poliovirus will still lead to an infection of the enterocytes, the cells lining the gut. However, that infection will not progress to the viremic stage and then infect the anterior horn cells. So the infection remains localized in the gut. They may still pass the infection on to other people. The wastewater will still be contaminated with the poliovirus, and if the population has good vaccination coverage with IPV, there will be no cases of acute flaccid paralysis.
IPV being inactivated polio.
The vaccine, correct. So there was a very interesting and tragic case of polio in New York State. It was passed 2-3 years ago, where a 23-year-old male was part of a religious community that declined vaccination, and he had not been vaccinated against polio at all. In the States, the vaccination that's made available is only the inactivated polio vaccine. He came down with paralysis, and eventually a diagnosis of polio was made. And the puzzling thing was why there were no other cases of polio. And so because of the SARS-CoV-2 wastewater surveillance program, there were wastewater samples that had been collected throughout the state. The teams went back to those wastewater samples and then also prospectively continued to look for polio. And they found them in a very widespread distribution in the state. And the reason for this most likely was that the vaccine-derived poliovirus that had infected this young man had been imported many months before. But because the population had been well vaccinated with this inactivated polio vaccine, infection with this poliovirus was still possible. Individuals were becoming infected but were at no risk of developing polio disease, but they were passing it on to other people. And this was evidenced through the wastewater testing. So I suppose I'm telling you that story for two reasons. The first is the importance of vaccination coverage with polio vaccine, whether it be the inactivated polio vaccine recommended by the WHO and used by most countries in the world, or the oral polio vaccine, which is a live attenuated polio vaccine used in the African continent for reasons that Bernard explained.
I did not know about this New York case. You said it had been introduced a few months before. Could it be traced back? What was its lineage?
There is excellent polio molecular surveillance being done across the world in a single center, that's being the Center for Disease Control in Atlanta. And unfortunately, that information is not publicly available. Unlike during the SARS-CoV-2 pandemic, when the genotyping and lineage of all strains were widely available. And this is something that the global community can really put pressure on the Global Polio Elimination Initiative, the GPEI, is for the opening of these resources and knowledge. So I'm sure that the answer is known, and that the case was very well described in the MMWR, that's the publication of the Center for Disease Control.
This is fascinating. Coming back to you, Bernard, just a couple of questions on management. First of all, is there any treatment for this initial phase of gastrointestinal polio? And how is poliomyelitis treated? How do we deal with the neurologic phase?
There is no specific treatment for the virus. And of course, because you can't really diagnose the gastrointestinal phase, even phase identification, as we just heard, is too laborious to be able to treat in time. But there are no drugs available, so let's just forget about drugs against the virus itself. Now, once paralysis sets in, there are all these other measures, physiotherapy, and then the prosthesis, for instance, against the falling foot, which is a frequent sequela of polio, so that people can walk more or less normally.
So now looking at transmission, Kerrigan poliovirus is transmitted by the fecal-oral route. As far as we know, how long can an infected person be infectious? And besides stools, Is the virus found in any other bodily specimens?
There have been some lovely challenge experiments where individuals have been infected with the oral polio vaccine. And because the oral polio vaccine is a live attenuated vaccine, and it's closely related to the virus itself, it's possible to mimic natural infection and then understand these very important questions, such as how long is someone infectious for and how long do people shed the virus. Obviously, when looking from an epidemiological perspective, we want to understand these facets of polio infection so that we can make and give good advice around infection prevention and control. So these challenging experiments have shown that an individual excretes polio virus for 2 to 4 weeks after infection, and that if an individual has a robust immune system, which most people do, their cell-mediated and humoral immunity will sterilize the infected cells so that they cannot produce the polio virus any longer within 2 to 4 weeks. It can be as long as 6 weeks. This means that it's possible for the individual to transmit infection with polio virus after they've been infected. So if an individual has been vaccinated with inactivated polio vaccine, their humoral immunity or their antibody immunity in the blood is very strong. Whereas if an individual has been vaccinated with oral polio vaccine, their humoral immunity and their gut immunity is very strong. This means that a re-challenge with a vaccine strain, in other words, an innocuous strain, will not lead to infection and the individual won't be able to pass on the virus. So oral polio vaccine is advantageous for a number of reasons. The first is that when an individual has never been vaccinated against polio or infected with polio, is vaccinated with oral polio vaccine, that oral polio vaccine is a live attenuated vaccine, a virus, and it will cause an infection in their gut, and they'll pass this virus strain onward, and any other children in the area who have not been vaccinated will be infected with that vaccine strain and will develop immunity. So not only is that child being vaccinated, they're also vaccinating other children around them. They will not be able to be infected with oral polio virus again because their gut immunity is strong. So this means that this oral polio vaccine is very advantageous in terms of global polio elimination. If an individual has been vaccinated with inactivated polio vaccine, if they ever come across wild polio vaccine or vaccine-derived polio virus or wild polio virus itself, they can be infected and pass that infection on, but they definitely will not get paralytic polio themselves.
Truly invasive infection. Just to follow up on that, has the virus been found in any other bodily compartments besides stool?
There is a short viremic phase, so there's replication at the site of infection followed by viremia, but diagnostic testing does not focus on that viremic period. It's usually quite short. The virus lodges in the neurological tissues. It's also possible to detect the virus in CSF, so cerebrospinal fluid. It's a neurotropic virus.
In terms of transmission, do we know the actual R0 of polio? And will this R0 that we think we know, if we do, will it change now that we have wastewater surveillance?
So the basic reproductive number in layperson's terms is the number of secondary infections that will happen when an individual who is infected finds themselves in a population that hasn't been exposed to the virus. The effective reproductive number then is when an individual who has the infection finds themselves in a population that has variable levels of immunity. So the basic reproductive number of polio is probably not known, but can be estimated to be around 18 to 24. It's incredibly high. What that means is that a single case individual with polio may lead to 18 to 24 secondary cases of polio. Now, because the asymptomatic to symptomatic ratio is such that there are very few symptomatic cases of polio, the infections, the onwardly transmitted infections, won't all manifest as paralysis. Only 1% of infections will show paralysis. or when we consider the scenario where an individual with polio infection lands up in a community where there's been variable vaccination, the effective reproductive number can range from 3 to about 12. One of the reasons for the long and large effective and basic reproductive number of polio is the fact that the virus is very hardy in the environment. So it can survive on surfaces, dryness, changes in pH. Influenza, by comparison, has an effective reproductive number of 3. Polio has a variable effective reproductive number because of the context in which an individual finds themselves. So higher socioeconomic and more affluent communities tend to experience polio outbreaks with lower reproductive numbers because of hand washing and good sanitation. That decreases the number of opportunities that an infected person may have to transmit the virus onwards. This has been quite a challenge for us to figure out the effective reproductive number of polio in different contexts because the literature is very broad and one never knows where polio may land up, whether, as we see, it may land up in New York State or in South Africa or in the favelas of Brazil. So there's quite a large variation.
Very, very interesting. Bernard, coming back to you, let's say we have a case of polio, a new case. What should we do in terms of infection prevention, transmission prevention? What are the measures that need to be taken?
Well, much depends on the context. In a population with a high vaccination coverage, there is nothing to fear from an individual case. There will be no epidemic and there will be no spread and no secondary cases of neurological polio. I think the most important thing, that would be the time to boost vaccination and to remind people that without vaccination, there is no absolute protection against serious diseases like polio. The difficulty, as we heard, is the delay in diagnosis, the fact that there are so many asymptomatic or post-symptomatic cases. So to limit the spread, you would have to accommodate a lot of people with sanitary measures that are unlikely to have any concrete effect on further neurological cases, which is really the important thing. But I think the most important lesson is this would show that you need to vaccinate and continue to vaccinate. That would be the message that you should give the public if such a case should occur.
Yeah, as you say, don't let a crisis go to waste. A good crisis should be fully used to the good. Thanks a lot. Let's turn now fully to rubella. That is a disease that really, I think, very few physicians have actually had to manage. And you, in South Africa, Kerrigan, are in the middle of an epidemic, an outbreak of rubella. Can you describe to us a little bit what that's like?
It's been an interesting time in South Africa. We are one of the few countries in the world, I think there are now 20 countries out of 198, I think, that have not implemented the rubella vaccine. Most countries use measles, mumps, rubella vaccine, the MMR. South Africa, for various good reasons, has been very slow to adopt the use of either the MMR vaccine or the combined measles rubella vaccine. And just some background to that is that we had a terrible TB-HIV pandemic over the last 20 years. And we also had advocates of various other vaccines, the pneumococcal conjugate vaccine, the human papillomavirus vaccine, that were deemed to have far greater public health consequences in our context than the public health problems associated with rubella. The other reason is that we are not a Gavi-funded country. So the Global Alliance for Vaccines Initiative, Gavi, supports low and middle income countries to introduce vaccines by adopting firstly a sponsored and then a transition program to self-funding. And Gavi has right from the outset used the combined measles rubella vaccine. So we have been using measles vaccine alone and not combining it with the rubella vaccine. This year, our Department of Health made a decision to introduce the rubella vaccine, but it has been something that has been discussed and debated at length. Part of the problem is that the introduction of rubella vaccine has to be conducted with sustained high vaccination coverage for a number of years. In fact, in perpetuity, otherwise one lands up not doing as well as nature in vaccinating or rendering the population immune. So what we've observed in South Africa to date is a seasonal rubella. Classically, in our surveillance programs, we see rubella peak every year from around about August, September to November, and that's the Southern Hemisphere spring to summer. It's quite curious as to why this happens. I mean, all diseases sort of have seasonal predilections. We see influenza during the winter and rotavirus that causes diarrhea during the winter. Rubella classically occurs in spring. The National Institute for Communicable Diseases, where I work, runs a fever rash surveillance program, and all persons across our country, which has around 60 million people in it, who present to the healthcare system with fever and rash, the clinician is requested to submit a throat swab and a blood sample for both measles and rubella testing. And so we've been able to document the seasonal phenomenon of rubella for a number of years. Now, what happened during COVID, interestingly enough, is that our country, like all the countries in the world, adopted various measures of severe lockdown and other non-pharmaceutical interventions, such as mask wearing and social distancing. Rubella is transmitted in the same way as measles, with a person-to-person transmission. It's a respiratory transmitted infection, and it has a very low effective reproductive number. It ranges from about 3 to about 7. The basic reproductive number is probably in the order of 12. It's a little higher, 11 to 12. But having said that, in practice, the effective reproductive number is closer to 3 or 4 or 5. So it's probably as infectious as influenza virus, but it's much less infectious than the Delta or the Omicron strain of SARS-CoV-2, which was around 8 to 10. So what happened during the SARS-CoV-2 pandemic was the non-pharmaceutical interventions effectively shut down the transmission of rubella, which is wonderful, but in the long term unsustainable. There have been some serological studies by a number of different groups using residual sera and looking at the seroprevalence of rubella in pregnant women, given that we don't have a vaccination program. And what we've shown is that around 95 to 98%, and sometimes as high as 99% of pregnant women in South Africa are immune to rubella. And what is that the seasonal rubella vaccinates, effectively renders immune through infection, successive birth cohorts of new children entering into the population who are by nature of life susceptible to rubella. So when the spring comes along, then there's a fever rash, little localized outbreak in the creche or in the school. Progressively over the years, young children up to the age of 15 become infected with rubella and then immune. By the time women reach reproductive age, there are very few women who are vulnerable to rubella. And for this reason, and perhaps I need to go back to answer one of your questions, is rubella infection in children is very mild. In fact, the very name rubella means little rash. And it was named in contradistinction to measles, which caused a florid maculopapular rash and a severe illness. Whereas rubella is a very mild infection in young children and even in adults. It has incredibly few complications as an acute infection. Very rarely children might develop low platelets. Some adolescents, particularly females, develop an arthralgia and sometimes an arthritis. There are cases, about 1 in 3,000 infections leads to a mild encephalitis, which is usually self-limited. So they'll get a very bad headache, and if you do a lumbar puncture, you'll find evidence of a viral picture on the cerebrospinal fluid. So rubella in itself is not a public health problem, acute rubella. Where there is a problem is when this infection occurs in a woman who's in her first trimester of pregnancy and she's not been infected with rubella virus or vaccinated in her life. There, the virus itself has a predilection for neurological and cardiac and sensory neural tissue. It infects the placenta itself, and then the virus localizes in these cells that eventually, in the organogenesis of a young developing fetus, become the eyes, ears, and heart. In these cells, it lands up affecting the cell structure and affecting cell division and causing premature cell death. So these children are often born with a triad of sensory neural deafness, congenital heart defects, and blindness due to cataracts due to direct retinal damage. This renders it a highly undesirable infection. It's a bit like Zika virus, in fact, which also causes a very similar picture as an acute infection in adults, but has teratogenic effects on the developing fetus.
There's no danger or elevated risk to the pregnant mother. It's entirely the fetus.
Correct. So I waylaid myself. I was telling you the story of why South Africa is experiencing this massive rubella outbreak. So what happened is that in 2020, when we had this lockdown, and for the rest of 2021, when our population, like across the world, was very nervous about SARS-CoV-2 and everyone was wearing masks and no one gathered together in big gatherings, there was no rubella. So there was no seasonal. And to give you an example, I think we used to detect in our fever rash surveillance around 1,500 to 3,000 cases of rubella every year. During 2020, 2021 and 22, I think we had 17, 23 and 19 cases of rubella detected. So there was no rubella, literally. Of course, you can appreciate then that children under the age of 10 at the start of 2020 and children who were born in 2020, 2021 and 2022, as well as 2023, had no exposure to rubella at all. And so then this year, when spring came along, oh my goodness, not only did we have the birth cohorts of children who in prior years, under the age of 10, who hadn't had exposure to seasonal rubella, we had 3 whole years of new children who were susceptible. And so we've had around between 9 and 11,000 cases of rubella detected in 2024 through our fever rash surveillance. Our laboratory, in fact, hasn't finished testing all the cases because we've been absolutely inundated. So what has given us some pause for relief is that when we've looked at the seroprevalence data from routine antenatal testing, which happens in patches across the country, persons of 20 years and older have had enough exposure in the past to have been immunized effectively against rubella through natural infection. And so the incidence in this outbreak of congenital rubella syndrome most likely will be higher than our background, but it will not, and we pray, be devastating.
Because you don't expect too many teenage pregnancies. Is this what?
Exactly.
Yeah.
And that is where the risk comes in. And so unfortunately, we do have a large social problem of teenage pregnancies in South Africa. When I say large, it's relative. We have a birth cohort of about 1.1 million new births, live births every year. And under 10% of these are born to teenage pregnancies. So there is a likelihood that we will see an increase in congenital rubella infection, but the magnitude of it we're not sure about at this stage. In our surveillance, in the 9 to 11,000 cases that we've seen, over 98% of cases are occurring in children under the age of 15 years. So we have very few cases that are being reported to us of infection in older age groups. However, the ratio of symptomatic to asymptomatic infection. So unlike polio, rubella cases are more apparent, but still about a third of rubella infections are asymptomatic. So an individual may experience mild prodromal symptoms of a fever and sort of body achiness, but they may not develop a rash, or they may be entirely asymptomatic.
Can you say how many people who will have a primary infection, how many will get a rash? How reliable is the rash of rubella?
Around 66%, so 2/3 of children and adults will get a rash. The rash is a very fine rash, and in a person with a darker skin, it might be undetectable. However, sometimes the rash doesn't appear. It is an immunologically mediated phenomenon, much like measles. So the rash appears at the same time as the appearance of more or less of IgM antibodies and the cessation of viremia or viral secretion in the saliva.
So let's do the whole timeline. You get infected on day 1, let's say. How long is the incubation period? When do you start becoming symptomatic?
Traditionally, we use the timetable of events that's used for measles infection. And so we count day 0 or day 1 as the day of onset of rash. So I wanted to put that out there. So we won't count day 1 as the day of infection. We'll
Fair
count
enough.
day 1 as the day of onset of rash. And the reason for this is that the immunological time course of infection is very easy to correlate when you have a clinical history of rash onset. So it's a kind of a landmark feature that you can say, right, on this day rash appeared, therefore working backwards,
Objective.
this is what was happening,
Yeah.
and working forwards, this is what's happening. So classically, the incubation period for rubella is longer than measles. It's around 14 to 21 days. An individual will start secreting virus from the oropharyngeal secretions slightly after the viremic phase has started, which is about 7 days before the onset of rash. Obviously, no case is identical and there's some leeway, but it's recognized that the period of infectiousness can start as early as 7 days before the onset of rash, and then the period of infectiousness ends between 4 to 7 days after the onset of rash.
After the onset, so even if the rash is still there, because it's an immune phenomenon.
Correct. So when we talk about minus 7 days, the way the graphs are constructed is the vertical axis shows the proportion of people with a positive test. So for example, a PCR test of the saliva will show whether the virus is excreted. A test for IgM antibodies in the blood will show when the IgM antibodies appear. A PCR test in the blood will show when the virus is present in the blood. And the graphs will show the proportion of people, or the proportion of cases that have a positive PCR test on day -7 or on day 0. And the graph shows a lovely curve, a bell-shaped curve, reflecting the sort of range of positive to negative results. So the infectiousness of rubella can surely be over between 4 to 7 days after the onset of rash. At that point, one can be assured that the vast majority of individuals who have rubella are non-infectious. One of the challenges with rubella is containing the virus. So Bernard was talking about the measures to contain polio cases. If an individual has polio and everyone around them is vaccinated, there's really no need for containment measures. However, in rubella, in our context, with this large outbreak, and we don't have a rubella vaccination program, there were lots of questions around, should we close schools? Should someone stay at home? What should we do? We've learned a lot from the COVID pandemic. Closing schools is a majorly disruptive thing, not only in terms of the practical logistics of who's going to look after the kids, but the educational impact is terrible. One of the problems is that 1/3 of people with rubella infection are asymptomatic. And the second problem is that when the rash appears, that person has been infecting other people for a period of up to 7 days prior to the rash onset. So we've advised our communities not to close schools, and that even quarantine or isolation rather of children with infection is probably not necessary, in the sense that the consequences of infection amongst children are minor and that the vast majority of the adult population is immune. We've advised really parents and caregivers to manage their children symptomatically. If the child has a high fever and they're not feeling well, let them stay at home. But from a public health perspective, we've not issued any guidance to contain the infection through isolation and school closure.
It sounds perfectly logical. And when you do shut things down, there are perhaps ramifications downstream with other organisms, surprises that by definition can't be foreseen years beforehand. Some last housekeeping things. What does that rash look like? Is it maculopapular? What parts of the body are affected?
Basically, the rash starts in the upper body, the face and the neck, and then progresses downwards. It is maculopapular. It's not as prominent or as clearly demarcated as measles rash is. It doesn't occur on the palms and soles, so one can't look at these as a guide. It doesn't cause Koplik spots as we see with measles, but even then, Koplik spots are not helpful. So there are a number of causes of maculopapular rash. There's a differential diagnosis, and this includes obviously measles, but then things like parvovirus B19, other Coxsackie or echoviruses, the exanthum subitum or HHV6 and HHV7 can also cause a very similar rash to this one.
What kind of virus is rubella virus? Does it have a non-human reservoir? Just the basics on that.
Yes, the rubella virus does not have a non-human reservoir. And this is one of the reasons why it's been targeted with measles for elimination. It has several advantages that render it very easy to eliminate. The first is that it has no non-human reservoir. The second is that it is a very stable virus. There is only one serotype. And even if there are genetic variation or genotypes, which there are, they don't lead to changes in antigenic structure. So the virus, unlike SARS-CoV-2, doesn't mutate and have variants. There's a very inexpensive and incredibly safe vaccine that is highly immunogenic. The vaccine is a live attenuated vaccine, but it doesn't have any changes in nucleotide sequence when it causes infection. So it's unlike the polio virus. It carries no risk for onward transmission. Because it may be combined with measles vaccine, there are mutual benefits. We can eliminate and eradicate 2 diseases with one program. It has been targeted by the World Health Organization for elimination along with measles, which would be a wonderful thing.
Just following up on your observation that there is only one serotype of rubella, does that mean that once you've been infected, you have lifelong immunity?
So rubella is what we call an immunizing infection. It elicits immunity that protects from subsequent infections due to rubella, and usually that lasts for the rest of one's life. It has been noted that there may be a decline in antibody titers in older persons, but it's suspected that these antibodies are present but just undetectable levels, and that re-exposure occur, there will be a boosting effect. So subsequent infection with rubella virus is incredibly rare. It has been documented, but it's very, very rare.
So the rubella vaccine is, as you say, it's particularly safe. Are you aware of any anti-vax sentiment that is directed specifically at the rubella vaccine, or is there rather a case of collateral damage after all of the misinformation trying to link the measles vaccine to autism? And because it's usually given with the measles, is it just collaterally lost?
We were aware during SARS-CoV-2 of a growing and emerging anti-vaccination sentiment in South Africa, and we anticipate that there will be residual fallout for the rubella vaccine. One of the advantages, perhaps in our context, is that the rubella vaccine will be given with the measles vaccine, and there's no objective change in our expanded program of immunizations. So we are monitoring the anti-vax sentiment through a number of initiatives conducted in the South African Medical Research Council and in work that is being done by the South African Vaccines Initiative, and we'll keep tabs on the impact over time.
We are now coming to a close. Bernard and Kerrigan, what are the key messages you'd like to leave our listeners with? Bernard, you first.
Well, regarding polio, this is a disease that's close to eradication. There is no treatment, so the only way to protect is vaccination. And as long as wild-type polio circulates, and as long as the live oral polio vaccine is in use in the world, the only way to protect the population is by a high vaccination coverage.
Thank you. Kerrigan, any last words?
Similar to Bernard, vaccination is incredibly safe, and the benefits of vaccination are something that extend not only to our little ones' lives, but to the lives of our community, population, and the world. A disease somewhere is a disease everywhere. Polio in Afghanistan and Pakistan could mean polio in South Africa tomorrow. The only way we can make ourselves safe is to investigate vaccination, understand the benefits, understand the risks, and make decisions to participate in vaccination programs for the benefit of everyone.
Thank you so much to our 2 guests, Kerrigan McCarthy in Johannesburg, South Africa, and Bernard Hirschel here in Geneva, Switzerland. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by myself, Angela Huttner, Editor-in-Chief at CMI Comms, ESCMID's Open Access Journal. It was edited by Dr. Katie Hostetler-Oy and peer-reviewed by Dr. Barbara Pichova in Antwerp, Belgium. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks, and any literature we've discussed today can be found in the show notes. You can subscribe to Communicable on Spotify, Apple, wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.